All right, so please ask questions throughout the presentation. As I said, there is quite a number of you guys here today, so please use the chat to talk to me. By the chat, I mean Menti chat, so please use menti.com. And without further ado, let's begin. So just to make sure that I know who is who and who is what, please fill in this attendance form. When you have finished the attendance form, please give me a hoy. At the end of this presentation, I will put this attendance up again in case you missed it. So fill your attendance in, otherwise you won't get your CPD certificate. So there's about 40 of you guys. So when we get to about 40, we'll move on from the attendance page. If this is your first time with me, you will know, sorry, for those who don't know, I use Menti because it has interactive quizzes. So please have Menti open so you can actually participate in the educational session, as I call it. Good morning to Yvonne. Please join us with menti.com, use the code and then mark your attendance very quickly. I'll give it another minute and then we'll move on to the next slide and actually begin our presentation. There is a few more housekeeping things that I must obtain. Like any good presentation, I need to see who my audience is and get feedback, etc. So I think the attendance has dropped off a little bit there. So we'll move on to the next slide. Again, if you haven't done your attendance, we can do this at the end, okay? Don't stress. All right, the next question for those who can move on. What best describes you guys? Fourth, the intern, good. First, third. Qualified staff sneaking in, I like that. Whoever asks me, how do you do that? You just go to menti.com, use your phone, and it's just interactive. So you click on the item and you move on from there. Some of the quizzes will require you to move a marker or mark on the X-ray image where pathology might be. So that's the game today. All right, so we have a lot of fourth year students here, which is good, and some first year students. So for those who are interns and fourth years, hopefully this is revision, and for the first years, welcome and good luck. All right, so what should you expect out of today's presentation? There are 4 common patterns on a chest X-ray, disease patterns, I should say, and I will be talking about 2 of them. I will be talking about some common radiographic signs. I will be describing in somewhat more detail than usual 2 common diseases that you might see on a chest X-ray. There'll be an image critique at the end and lots of quizzes throughout. All right. So the fundamentals of chest X-ray, there is a lot to cover. I've got a 2-hour time slot and I'm really hoping not to go over because I've got a lunch at 1:30. So let us move on, ask questions throughout. So first question, put a pin on the left lung. So on your phone, on your computer, there should be a blue dot. Move that blue dot to the left lung. Excellent. This is good. This is how this tutorial is going to work. Interactivity, please participate. This is an easy question. All right, I think we'll move on from this question. Pretty self-explanatory. And yes, well done. That is the left lung. The next question is, put a pin on the gastric bubble. On the gastric bubble. Now, of course, you can see where everyone's put their pins. So don't look at the answers before you've had a go yourself. Now, this isn't really a test. It's just a gauge, a bit of an icebreaker for you guys to see how this presentation will work. But I will be going into more detail later about the anatomy. I'm not going to throw you straight into the deep end just yet. All right, so I think we'll move on from there. The 26 people who marked that exact spot is correct. That is the gastric bubble. The rest of you guys are close, but not quite close. So the gastric bubble is what we refer to as the air fluid level component. So where you've marked is probably the stomach, but it's not the gastric bubble. All right, on this lateral, can you please mark for me? Sorry, my slides haven't moved on. Sorry. On this lateral, can you guys please mark for me the posterior costophrenic recess? Posterior costophrenic recess. Awesome. So the 28 people and the two outlier dots there, well done. The person in the front, that's middle, man. Moving on. Now, the next slide, I want you to please mark a little bit harder the trachea. The trachea. And again, for those who didn't hear the first time, in the Zoom chat, I have posted a Google Drive link. You are very welcome to download the higher definition images of today's presentation. They're all available on that Google Drive link. Now, we will move on again. For those, pretty much everyone is in the right ballpark. A good way to tell on the lateral if what you're looking at is the trachea is that the trachea must bifurcate. And because your left and right bronchial branches don't lie in the same plane, your actual left bronchial bifurcation goes more posterior. You can actually see the bifurcation here. And so this must be your trachea. 15, 11, and 4 are pretty accurate there. All right. So the next slide. All right. So we won't spend too long on this. The couple of things I want you to note from this image is that the left-hand side has 2 lobes. The right lung has 3 lobes. You have your horizontal fissure, your oblique fissure on the right. And then your left has an oblique fissure. Now, for the first years, hopefully you have realized that the image is reversed. So your left is the image's right, or the patient's right, and your right is the image's left, because we always view the images in anatomical position. Please remember that. Otherwise, this presentation is going to be a very long one. Something else to note is that the couple of regions on the chest x-ray that I want to bring your attention to, you can see the gastric bubble there. This is what we call the cardiac silhouette, the heart itself. This is the mediastinal structures, or the hilum. And up here where you see your trachea is called the, I've gone blank. The vascular peduncle or the pedicle. The vascular pedicle is up here. I'm so sorry. I've only had half a cup of coffee this morning. So the vascular pedicle or the peduncle up here is really important in one of our pathologies later, which we'll talk about. The costophrenic angles on the sides here, and all of these white lung markings, we often can't really say what they are. So we just call them the hilal structures or hilum structures. And they're essentially your pulmonary arteries and your pulmonary veins coming out of the hilum itself. All right, so on the lateral here, this is actually a rotated chest x-ray, just FYI. Would you repeat this? Probably not, but I would be very disappointed if a fourth year student produced this image. Gastric bubble is there. The heart silhouette, remember this is now the anterior surface as opposed to the previous lateral that I showed you before. And this is the posterior surface here. These are your costophrenic recess, and you can see your thoracic vertebrae very nicely here. Now, as I mentioned before, the first part of this presentation is going to be on chest x-rays itself, so pathologies and all those kind of things. The second half will be for image critique. I've done that on purpose because I know in today's audience, there's a couple of non-radiography students, so I didn't want to bore them with the technicalities of things, but you're very welcome to stay if you wanted to attend that as well. Now, all right, first question. When everyone is ready, we will have our first timed quiz. So what that means is the faster you answer the questions, the more points you get. And at the end, there is a virtual trophy to give out. All right. We shall proceed, I think. I think 38, 39 is pretty good. All right. Which diaphragm is the left side? Which diaphragm is the left side? Now, of course, to some of the first years, second years, it will probably be a disadvantage. To the medical students, probably a disadvantage as well, but that's how life works. All right, 3 more seconds. Everyone's answered. Let us see. Oh, we have a split. The blue line is the left diaphragm. All right. Now, let's have a look at the tally first. Okay. The first one was a freebie. Everyone that got it right got full marks. All right. Now, further along today, I'll explain why that image, the blue line, was the left side. But for the moment, that was just another example of another type of quiz that we're doing today. The first thing we'll talk about is radiolucency. The lung is more radiolucent than bone, and it obviously appears darker. And in some cases, because of how radiolucent it appears, it may lack vascular markings. An increase or decrease in the radiolucency of your image could suggest a pathology there, especially if that radiolucency is different depending on the location. In other words, what I mean is the radiolucency should be uniform from top to bottom in both lungs and comparable at the same level. So at the level of the hilum, the radiolucency should be the same. Irrespective of what type of technical error the radiographer has performed, X-rays will expose both lungs the same. So the only way that you will have a change in radiolucency of one lung as to oppose the other lung is if there is pathology that's causing that change. So just remember that both sides should appear visually appealing the same way. Oops, sorry. All right, so this image, if you have a look at it, what do you notice straight away? The left side is clearly whiter or brighter than the right side. And so the first decision that you need to make is, what is going on here? Okay. So we also know a couple of things. We also know about our adequate inspiration rate. So if you guys count your ribs, it might be hard to see, but that's the first rib. First rib, second rib, third rib, fourth rib, fifth, sixth, seventh, eighth, ninth, 10. Now, to me, it looks like the right side has a hyperinflated lung. The diaphragm is compressed and it looks quite flat. If you look at the left side, it's a nice dome shape. Your diaphragm is a very strong muscle. It should be quite round. And I guess in a way, you need to think about where is the pathology and where is the compensatory effect. Compensatory effect is our body doing something to compensate for the lack of something. So in this case, the left side is quite white. So we could say that there are some consolidative changes in the left upper lobe here. This consolidated change has actually forced our body to over-aerate the right side, which helps in our diagnosis, because what this tells me is whatever this side is, it must be a pathology that is restricting the aeration of the left side. So our body has overcompensated by overinflating the right side to help you breathe. And this is something to note. So the pathology isn't actually the right side. It looks quite dark, but it's actually the left side that has caused the right side. So this overinflation is secondary to this primary cause here. That's something to note as well. Now, there's lots of information, but the first couple of slides is kind of just a bit of a ramble about different things, but then there's more structured content. So you can actually see this image here is actually the same patient of the previous image. Can you see how the left side, for whatever reason, has become quite tight, quite bright, quite fibrous, if you like? And so what's happened is the right side has overinflated to a point where there is what we call emphysemic destruction. So this side is emphysema, and this side is atelectasis. And they coexist in the same way because there's a balance. And it's our body's way of trying to maintain this homeostasis balance. And unfortunately, it's backfired because whatever has caused this has made the lung overinflate the right side. This has occurred, this emphysemic change. And that's a very common thing. If you get long-term atelectasis or long-term high-grade pneumonia or long-term high-grade COPD, there might be compensatory emphysemic effects on the contralateral lung to offset the lack of breathing. Or it might happen in both lungs, because COPD rarely occurs unilaterally, and it often occurs in both lungs. So this is an example of maybe, for example, long-term fibrous change. It could be radiation therapy at a young age to one side of the body, and then as this person has gotten older, the other side has overinflated over many, many years of life to become the state it is now. It could be a carcinoma in the left lung over many years of smoking. I don't exactly recall the clinical history, but these are possibilities. All right, so I've lost my mouse. Points to consider on this chest X-ray. What pathology is demonstrated? Hopefully, for most people here, you'll recognize there's quite a large white density, a white opacification in the left side of the lung here. If you compare it at the same level as the right side is markedly more normal. Now, is it 100% normal? Maybe not. We don't know. There could be compensatory effects here too. But for the most part, the big pathology here is this left-sided thing. Now, there's another key radiographic sign here. This is called the meniscus sign. Any fluid inside a volume, according to physics and chemistry, as you recall, has a meniscus. The walls will attract the liquid up and it'll form this curved shape. And because this is a fluid inside a closed vessel, the lung, this is your meniscus. So this tells us very, very well that this is a left-sided pleural effusion. The pleural effusion forms because there is an imbalance in some process, or there is disease that is causing liquid or fluid to permeate through your vessels into the pleural space, the space between your parietal and visceral pleura, and the lung has now probably collapsed a little bit. So a lot of the times we describe this as pleural effusion, but at the same time, we can rightly say that there must be some form of atelectasis. Remember, the atelectasis is what we call lung collapse. So there must be some form of lung collapse in this left side, whether it be a little or a lot. The reason why I know this is because the rib cage prevents the lungs from expanding. So there is no other physical space that your lungs can go if there's fluid that's not meant to be there. So these things coexist, but often we describe this as a left-sided pleural effusion. Has this increased or decreased your radiolucency? It has decreased your radiolucency. It's become darker, so it is more radio dense. What treatment options do we have? The most common is a thoracocenthesis, or the more layman's term is a pleural tap. We literally shove a tube into the patient's pleural cavity, and then we drain the liquid. We probably will drain it slowly. There is something called re-expansion pulmonary edema. Very rare, but it can happen if we rapidly expand our lungs to refill the void or the space it used to occupy, especially if this patient is a long-term candidate for pleural effusions. With a pleural tap, for those who are interested, when the clinician or the radiologist inserts a pleural tap, the actual pleural tap will usually go over the top of a rib, never underneath a rib. So there is two ribs, the top and bottom. We always slide the catheter tube directly over the top of the bottom rib and never underneath the bottom of the top rib. The reason is directly underneath the bottom of every rib is what we call the neurovascular bundle. If we stab that with any device, we'll probably end up with a patient bleeding, and we'll probably need vascular surgery to try to fix that. So the radiologist, or even in the wards when they do it blind, they put their fingers like this, feel the ribs, and slide the catheter over the top of their finger for the bottom one, as opposed to underneath the top of the bottom one. Someone asked me this question, and I'll show the group. If atelectasis is related to partial lung collapse, is it a synonym with a pneumothorax? Yes, 100%. The pneumothorax is the cause of the atelectasis. Similarly, the pleural effusion is the cause of the atelectasis. The atelectasis, by definition, is an umbrella term for lung collapse, period. That is what it means. It is lung collapse, or lung unable to do its function due to it not being able to aerate. So things can lead to atelectasis. It must have a volume reduction. The volume itself must be reduced. Thank you very much. All right. And how do I close this thing? Close this thing. All right. So We'll move on to the next slide. The question that I have to ask you guys is, what is the pleural fluid made up of? The pleural fluid is made up of whatever it is that is causing the pleural effusion. The pleural effusion is, again, an umbrella term for many different types of things. So we can have clear fluid. So when you drain the pleural effusion, liquid comes out, and the radiologist or the clinician will make a comment on the color of it. The color of it is usually a good indication of what we think might be in it, which in turn will give us an idea of what may have caused it. In my workplace, because we work predominantly with oncology patients, almost all of our pleural effusions will be a yellow cloudy color. Yellow cloudy color is high in cells, high in protein, high in lots of things that have escaped the cells. That means, for predominantly, unfortunately, these are pleural effusions caused by cancer cells. If you drain a pleural effusion and there's lots of clear fluid, or it's quite, yellowy, but not dark, then we would say that's a transudate fluid, and a transudate fluid is often related to blood vessel changes, hydrostatic pressure changes, cardiac changes. So the patient could have congestive heart failure, pulmonary edema, all those kind of things can cause pleural effusions as well. Did you guys happen to see the surgical clips in the right supraclavicular fossa? If you haven't, have a quick look now. There are 3 surgical clips there. The patient's history is very, very important. This particular case study, the surgical clips, was from a previous melanoma resection. And of course, unfortunately, because melanoma is a silent recurring disease, this patient unfortunately has a relapse melanoma. So the melanoma is the cause of that pleural effusion. What other imaging modalities should happen, or should occur, I should say? Because now we know that this patient's pleural effusion is most likely from a cancerous origin, 2 things should happen. The first thing is a PET scan. A PET scan should occur, positron emission tomography, with probably FDG. And the reason why is we need to see whether this particular melanoma has relapsed somewhere in the chest, or is it somewhere else that has now moved into the chest. And CT might be useful, but first and foremost, you should always do a PET scan to look for avidity of FDG. And of course, cytology has confirmed that it was a relapse metastatic melanoma. So by cytology, what we did was they would have drained the pleural effusion, sent the entire bag to pathology, and pathology would have done some cytology testing and cell testing and found that it was metastatic melanoma. Now, common chest X-ray patterns. These are the 4 most common ones that I would often try to describe to students. In this presentation, due to time constraints, I will only be covering atelectasis and consolidation. The other 2 can be for another rainy day. Now, my very first thesis mentor always said to me, sometimes it looks like shit. Don't try to make it sound fancy. And what this means is sometimes the image that you're looking at is just pure crap. Like, unfortunately, the patient has deteriorated in such a way, there's just no real way to describe it in any sense or any way. So often in radiology reports, you'll see the radiologist say, bilateral airspace opacifications, hazy appearance throughout. Because even they can't really put a name to something like that. They may say, with the clinical history, it suggests that it may be XYZ. What I'm describing for you today is when the examples that we have seen are solitary and easily defined. But often in a very complicated case, atelectasis, consolidation, all these things will coexist. And so it's often quite hard. So don't beat yourself too hard if you can't name that particular pathology. What you need to be able to do is tell me, Hung, there is pathology. It looks white. It looks dark. I don't know what it's called, but I think it might be this. And that's fine. You get more experience. And I don't say that I'm an expert at this, but I have done more work, and hopefully I'm able to help you guys more through your journey as well. Oh, and last time at the end of the presentation, of another presentation, someone asked me what qualifications do I have to be doing this type of presentation. So I have a master's in CT, computer tomography, and I have a master's in image interpretation and radiographic image interpretation, in case you're wondering. Now, as I mentioned before, atelectasis is reduced lung volume. If it is a lobe collapse, we can rightly say lobar atelectasis. And in some textbooks, that is what they'll call it, lobar atelectasis, which means lobe collapse. In your lung, as I mentioned earlier, there are 3 lobes on the right, 2 on the left, and these are their generic locations. When we have lobar collapse or lobar atelectasis, they will usually collapse inwards onto themselves and into the area of least resistance. When they collapse, they will move the structures in which they are anchored to with them. And these structures are your fissures. You always have elevated fissures or dilated fissures or translated fissures, sorry, when you have lobar collapse. Key signs. When they collapse, they generally collapse in a very predictable way. For example, and I do have to mention that these can be found on the internet. Radiopedia has lots and lots of articles about lobar collapse. So please feel free to head that way after this presentation. We'll look at panel D first, because it's often the easiest. Panel D, if you have a look at here, this green outline, which outlines the right upper lobe, corresponds with this. Due to the location of the actual lobe and how much it attaches to the chest thorax cavity, if this collapses for whatever reason, it will often collapse upwards, because a lot of the walls and the chest will keep it attached. So the fissure will move upwards and it will often move inwards, okay? So you'll normally see a little triangular shape in the top corner here. The orangey line here is your right middle lobe. Now the right middle lobe attaches, borders the heart quite nicely here. And so when that collapses, you often see a second outline or a second shadow just next to your right heart border here. That's almost always indicative of a right middle lobe collapse. This red border here is your right lower lobe. And for the most part, that will collapse downwards towards your diaphragm. And likewise, on the left side, this ginormous lobe here, your left upper lobe, will often collapse anteriorly because it's more attached anteriorly than it is obviously posteriorly. And it will often collapse laterally because it's more attached that way. This red one here will often collapse inwards and towards the heart. So again, you see this nice little outline, and in literature you often hear it being called the Sale sign and that kind of stuff. All right, so we will go into some more quiz. Now, I don't have enough time to really go through everything in detail, so please just take it as it is. Look at your phone. What pathology is exquisitely demonstrated here is a Sale sign. Any ideas? This is a typing exercise. Type in your answer, please. You may not get it right. That's fine. This is just to give me a break from talking as well. Abbreviations are fine as well. It's much more different when I don't give you the options, isn't it? Sale sign, lung inflation. So the answer is left lower lobe collapse. So sale sign is correct, not left upper lobe, not that one. Yes, that would be correct. Left lower lobe collapse, and this one and this one. Perfect. So we'll have a look at the picture again. You can see this nice straight line here. That is what we call the sail. That's your heart silhouette there. This is an indicative sign of a left lower lobe collapse. You actually can see the posterior costophrenic angle here as well, and that's very rare. The reason why you sign it will be explained later in this tutorial. All right, moving on to the next question. What pathology is exquisitely demonstrated on this image? I'm so sorry, the image is so small. I didn't realize how small it was. And again, for those who are interested, you can obtain a copy of all of these images that are here via the Google link, which is via the Zoom chat. Right middle lobe collapse, correct. Well done, two got it right. So right middle lobe collapse, yes, atelectasis, not dextrocardia. Dextrocardia is when the heart is reversed, but your heart was still facing the left and your great vessels were still correct. Not dextrocardia, not consolidation, right upper lobe, no. So well done to those who got that one right. Oh, so there's some options, sorry. Didn't realize. Right lower lobe, nope. Right lung collapse. No, I won't give that one away. Right middle lobe collapse. No, that's lower lobe, middle lobe, middle lobar. That's why I did mark it right. And yep. All right. The reason why I have to mark it is it gives you points. So you can see here that this is your second border. You can just faintly make out your cardiac silhouette around it there. This is an example of a right middle lobe collapse. Now, because the right middle lobe has collapsed, it's actually caused tracheal deviation as well. Remember what I told you, when something collapses, it pulls structures towards itself. It is a pulling structure, and you can see a tracheal deviation towards the right side, which is another indicative sign that there's something on the right side that's causing a tracheal deviation and mediastinal deviation as well. So this patient most likely is having lots of shortness of breath, dull sounds on right side, and left should be fine. All right, so here's the leaderboard now. Let's see who is leading. All right, so we have, no, Jasmine Simon is still leading. All right, so we're going to talk about push and pull pathologies. All right, push and pull pathologies. Have a look at the images here. Can you guys see the giganormous whiteout? This is what we call lung whiteout. This lung whiteout is on the patient's right-hand side, and there is tracheal deviation towards the left. Whatever this pathology is, has pushed the trachea away. So this pathology must be a space-occupying pathology. It must be something that is causing the lungs to become compressed. So this is an example of a large right-sided pleural effusion with compensatory atelectasis. Your right lung must be compressed somewhere in this white mass, and the whole thing, all that fluid has pushed the lung away. If you look at the right side image, you can see that the image is an example of a tracheal pull. The white mass or lesion has pulled the trachea towards itself. And this pull could be a few different options. It could be a lobectomy. It could be pneumectomy. It can be true atelectasis, where for whatever reason the lung has collapsed and that has forced the trachea to pull towards itself. If you have a quick look at the image, that arrow is pointing to this little thing that's sticking out of the middle apical kind of region there. And that is, according to the literature there, a example of a mediastinal mass. And the mediastinal mass has caused that right lung to collapse. And because that's collapsed, it's pulled it towards itself. So you might be able to also appreciate an overinflation of the opposite lung as well, the contralateral lung. The diaphragm, the dome of the diaphragm is flat, like it runs horizontal and then down, as opposed to this diaphragm, you can just make out, it runs up and then down. So this is another example of how looking at your physics and looking at your compensatory effects will help you determine what pathology might be presented here. All right. So in terms of atelectasis, oh, sorry, I think I've got too far. Oh no, sorry, I've gone too far. All right, this is the actual slide. Another quiz. So look at your phone. Is this a push or pull pathology? Push or pull? Is it pulling towards the pathology or pushing away from the pathology? All right, so it is a pull pathology. Have a good look. Oh, I didn't provide the image, silly me. If you have a look at the image again, can you see how the trachea is deviated towards this white mass? This white mass, trachea, deviated towards the white mass. This question is asking, what do you think the pathology is? What do you think might have caused that? And I mentioned it previously. And of course, you may not know the answer, that's fine. Remember, clinical history, I haven't provided any clinical history. So it is anyone's guess, really. The answer is a standard pneumectomy. So anyone that might be truly close. Left lung collapse, I'll give that one. All right. Now, hopefully, yes. So this is a coronal slice of the same patient. And what has happened is obviously the left side has been completely removed. So your heart and mediastinal structures has shifted towards the left to fill that void that was there. So all of that white stuff that you saw was actually the mediastinal structures. Can you also appreciate the diaphragm here? This is obviously part of the liver, but the diaphragm that runs here is actually quite flat. The right side overinflates because it is the only lung left. So it's doing the work of two. So you can appreciate there the flatness of the diaphragm as well. And strangely enough, the flatness of your diaphragm is mentioned quite a lot in another pathology shortly as well. Would you have been wrong if you said there was probably a lobe collapse? Probably not. Remember, we haven't been given any clinical details. You don't know why the patient presented. So if you had said lobar collapse, pneumectomy, if you had said complete whiteout, anything is possible. All right. So this image is quite green because I suspect it was a film screen. So someone has printed this image onto a radiographic film. And then when the digital era came about, they have now scanned it back through with a low quality scanner. However, this is classic of the old kind of scanning techniques. In the very beginning of this presentation, I mentioned upfront that there's nothing that radiographers can really do to cause this appearance where one side is black and one side is white. It's impossible, because you must x-ray both lungs with the same amount of photons. So there must be some pathology in this image that has caused this. This is something that you need to get straight away. Sometimes I give this image to students and they go, oh, it's overexposed. But it's not overexposed, because if it's overexposed, both sides of the lung should be overexposed, right? So this is not technique. The radiographer has not produced a suboptimal image. The quality of the image at the presently is suboptimal, but in its prime day, it probably was a very good image. I've written there, what is the treatment options? Can anyone have a guess? Group chat, speak up with the microphone, I don't mind. Anyone have any ideas what the pathology is here? Oh, everyone's too scared. It is a pneumothorax, a right-sided pneumothorax. Do you guys notice the right heart border here? The right heart border is not a right heart border. The right heart border should never, ever have this appearance. It should be a nice curvy appearance like this side. Can you also appreciate slight tracheal deviation towards the left? A pneumothorax is a space occupying pathology, because we introduce air into the space. Air doesn't get absorbed very easily, especially in this volume. So it just fills the void and then it pushes the lungs. And this is actually total atelectasis. This is the entire right lung squashed into this little corner. So the patient must have cardiac tamponade as well. Like, surely with that much pressure being exerted onto the heart, they must be feeling some chest pain as well, along with the shortness of breath. And you can see here, this left side is doing overtime at the moment, because it's coming quite dense. So all the vessels are dilating, trying to get more oxygen through, trying to get more carbon dioxide through for the gas exchange. So in the early stage of a pneumothorax, my understanding is that the contralateral side often becomes quite vascular. All the vessels engorge so that more oxygen and more carbon dioxide can be exchanged. And that's where you get this nice white appearance. Treatment options, this patient needs urgent decompression. So what that means is, the word decompression is to decompress, to reduce the pressure. So similar to a pleural effusion drain, they will put probably a water drain or a floor drain into this patient's chest to try to reduce this pneumothorax. In terms of radiographers, what do? If you saw this image, you put the patient straight onto a chair. They should not be standing, because they could collapse any moment. And you pretty much call a nurse to do some set of obs, or you do the set of obs if it's part of your practice, and you notify a radiologist immediately. Sometimes there might be a pneumothorax post-surgery, which can be expected. But if the patient has come from the waiting room and they've just been going about their daily life, this is what we call a spontaneous pneumothorax. It's probably something that needs to be looked at very urgently. All right. So this is what I mentioned before. This is the same patient as previously. You can see now the left side is no longer as vascular. So both lungs are now inflating. Again, remember, it doesn't matter what the radiographers do, you can't possibly make the lungs look different on either side like this. Is impossible. So there must be pathology on the right or left. In this case, it's probably the right side, because that was the side that had the pathology originally. And this is what we call re-expansion pulmonary edema. The literature says that they're not really sure why it occurs. It could be genetics. It could be changes in the patient's lung, in the sense that the lung was getting used to that compression. So often re-expansion edema occurs for people who have long-term compression of their lungs. And when it re-expands, it's not used to that expansion. So then fluid just leaks everywhere into the lung itself. What escalation steps would you take? Again, you would call the most senior medical practitioner, whether it be a radiologist, or you might call the emergency doctor if you're working ED to tell them that their patient has now had re-expansion pulmonary edema. Now, some of these pathologies I haven't mentioned before. I just wanted you guys to have a go at it. Drag the slider to either push or pull, and I will tell you the answers. And this is just a way for you guys to hopefully remember in the future. Have a go at it. I'll give it another 30 seconds. All right. So radiation fibrosis, pretty much neck and neck. You guys have said neck and neck that it's a push and pull pathology. Radiation fibrosis is traditionally referred to as a pull pathology because the radiation itself causes fibrosis of your lungs, reduces the elasticity of your lungs, reduces the elastin in the actual walls of your lungs. Therefore, it constricts. That constriction causes a pull. So often you see tracheal deviation towards the side of the radiation fibrosis. And total lung collapse, when the lung collapses, similar to radiation fibrosis, that lung constricts on itself. And if there's no other pathology countering that effect, it will pull towards the side of pathology as well. Pneumothoraxes, again, you guys are pretty much neck and neck there. It is a pushing pathology. Pneumothoraxes obtain air from an external source. That air has nowhere to go inside the body. So when the air is inside the lungs, it must push away to fill the space, basically. The bullae is a thin wall or no wall gas space, and it will again push away, similar to pneumothorax. Bullaes are quite common. Some people don't know they've got bullaes, but if they get big enough, it will become a problem. And then solid consolidation is a pushing pathology as well. All right. Are there any questions so far? Anyone from the audience at all? Now, I know that this tutorial is very jam-packed, but it is my first one for this quarter. So I just want to gauge the audience. And what I'm going to do is after today, I will think about the next few topics and then send another invitation like as I do normally. All right, so if there are no questions, we are going to move on to OneNote. Now, OneNote. All right, so this is a live interactivity. Everyone can see the screen, yeah? Good. I'm not talking to myself here. Everyone's still there. All right. Excellent. All right. So instructions to Hull. Draw on the anatomy. All right. So trachea is down here. Everyone got that? You can see your hilus structures here. So this will be your pulmonary artery plus veins. You can see your, I'll change it to blue. Your heart structures here. Okay. You can see your clavicle here. Okay. And let's make it green. This space is called your vascular pedicle. I'm just going to quickly rub out the heart and the trachea. On this patient, it's not too obvious, but in some patients, this is the aorta just there. Okay, that's the aorta. Now, the aorta obviously goes around behind the posterior border of, so the posterior part of the aspect of your heart. Normally, it sticks out a little bit more than that, but on this patient, it doesn't. So this location is called your aortic knuckle. Okay, where it normally bulges with the heart. So that's the aorta there. And that would be part of the heart. And that's the little indentation. Okay. Let's have a look. What else can I tell you? This is your anterior costophrenic recess. Remember, your posterior costophrenic recess will probably be down here somewhere. The reason why we can't see it is because the abdominal structures are too dense and it superimposes over the top. All right, moving on to the next one. Now, this is your lateral view. So again, this space here is called your, how do I do that? That's called your retrosternal space. This is called your retrocardiac space. Oops, can't spell. You can see your heart shadow here. You can also make out your trachea. Let's make it blue. That was a terrible job, Hung. Okay. You can see a density here and a density here. This would be your right pulmonary artery. And this density here will be your left. The reason why I know that is the left pulmonary artery will cross behind the trachea and go posterior. And so we know that for a fact. And therefore you can see the left pulmonary artery there behind the trachea, and the right pulmonary artery sits in front of the trachea. You can see your humerus here. You can see the skin flap here, the posterior aspect of the patient's skin here. And you can also make out more red. Oops, I've just dropped my pen. Hang on. All right, and you can also see your esophagus coming down here as well. Okay. Anything else? Nope. All right. Next page is common tubes. So I've taken the liberty of labeling these beforehand. This green one that starts up here, number 1, this green one here that goes all the way to here is called your NGT, your nasogastric tube. If the tube continues on and goes down here, this will be your NJ tube, your nasovaginal tube. This is your ICC, your intercostal catheter, to drain a pneumothorax or to drain a pleural effusion, for example. This red line over here is your PICC, your PIC, peripherally inserted central catheter. This shorter red one here should probably be a little bit thicker. And this is your endotracheal tube. Endotracheal tube. And that's for intubation purposes. The endotracheal tube will sit inside your trachea. Endo meaning endoscopically inserted or inserted into the, and it should sit 2 to 3 centimeters above your carina. This is your carina. Oh, sorry. This is your carina. This bit here, the pointy bit. This lovely blue diagram with the word CT is what we call a port. Just for reference, a port is not all made the same. Not every port is CT compatible. You must make sure that your port is CT compatible before you put contrast through the CT port. So through the port. Because if the port is not rated for CT and you inject via it, there is a potential that you actually might damage the actual port. Okay, so be mindful of that. All right, so there is another little green line here. The little green line is another form of a CVC, a central venous catheter. And it's just a jugular line, or some places just call a CVC. So this is just another form of a CVC. Now, CVCs have different purposes and different names. Depends on the make, depends on the model, and depends on the purpose. But all of them should end up in this location here. Okay. That location is called the sinoatrial junction, and that is just outside the right atrium. Okay. Atrial junction. Okay. Now we'll go on to Wallani. All right. So, just very quickly, just remember your heart chambers. I have to draw in green. Remember heart. Remember blood enters your heart via your SVC and your IVC. It fills this chamber here, which is your right atrium. Then it flows into your right ventricle. Then the blood gets expelled by the heart into your lungs via the two pulmonary arteries. Remember, your pulmonary arteries are deoxygenated blood, although it's an artery. Okay. Blood is oxygenated via the capillary beds at your alveoli and then returned back to the heart via your pulmonary veins. It fills the, my apologies, fills the left atrium. And then during systole, the blood is sent out of the heart via your aorta. Okay. The one thing that you need to remember in this tutorial is that, in any part of your professional career, is that if there is a backlog of any form of fluid, whether it be blood, whether it be urine, whether it be feces, whether it be gastric juices, for example, there must be a compensatory effect. Something must give so that this backlog doesn't explode. That is essentially how the body works. If there is a backlog, there must be a compensatory effect to prevent the body from imploding. Okay, so we're going to look at pulmonary edema now. So are there any questions before I move on to that bit? Nope. Very good. Not this one. Oh, hang on. I haven't been opened yet. My apologies. All right, I found the PowerPoint I'm looking for. Sorry, I was reading a text message actually. Hello, this is PowerPoint. So we're doing something a bit different now. I don't like to recycle stuff, but one of my mates asked me to do a little presentation on pulmonary edema. So I thought, save me some work. I've recycled some work. Okay. So this is called the secondary pulmonary lobule. The secondary pulmonary lobule, or just a lobule, or the SPL, is what we call the most functional unit of the lung. And this is how radiologists will often describe their appearances. This is that honeycombing effect as well. So if there is a honeycombing effect, it usually affects the periphery of this SPL, giving you that classic kind of like cell-like appearance through your HRCTs, etc. What is there to know about the SPL? Well, the SPL, we can treat it like a functional unit. So if you recall in your anatomy classes, the arsonist contain all of your alveoli sacs, and then the arsonist is like, I guess, an individual bundle of grape, if you like, and each of those grapes is an alveoli itself. So imagine each of these arsonist sacs or bundles is a bundle of grape. So often diseases will affect an individual bundle and then move on to other bundles. And then when those bundles are no longer able to cope, they will then affect the interlobular septa and then affect the neighboring lobules. And that's how disease spread. It spreads locally within itself in this SPL complex, and then it moves into different parts. Remember though that on imaging, it's not possible to see at this level. So all the pictures you see of the SPL are generally just a shape and maybe a dot or some lines going through it. Also remember that the SPL is a three-dimensional shape. So for example, if this was the SPL here, the actual vessels will be running through the middle of it, right? And coming out the other side. So what we've done is sliced horizontally in the axial plane to obtain this image. So some of the descriptions you'll hear might be a bit confusing if you try to think about it in a two-dimensional plane. You have to think about it in a three-dimensional plane, okay? There are a couple of things that are not indicated on this left picture by the great Dr. Gallard, which is the lymphatic system. So I've included that here in this image. The lymphatic system is very important. It drains away any excess fluid. A disruption to that might cause an imbalance and lead to things like pleural effusions and pulmonary edema and that kind of stuff. All right, so the next slide. So this is my example of a SPL, systematic one. The blue line is your pulmonary artery because it contains deoxygenated blood. I've made it blue. And then the red line is your pulmonary vein. And because it carries oxygenated blood, it is red. In this diagram, I've omitted the lymphatic system. I've also omitted the capillary beds because there must be a connection between the blue and the red somehow, but they're too tiny for our eyes to see and too tiny for imaging to pick up anyway. And this grayish line here is your centrilobular bronchiole. So it's like the terminus bronchiole. So your trachea bifurcates many, many, many times into your divisions, and finally it enters an SPL as a terminal bronchiole. So it terminates there. All right. So pulmonary edema can be thought of as two processes. Either it is heart related, so cardiogenic related pulmonary edema, or non-cardiac cardiogenic related pulmonary edema. For this presentation, I thought it'd be more interesting to talk about pulmonary edema that's caused by the heart. So we'll talk about that. But just very briefly, we'll discuss some non-cardiogenic causes. Pretty much, by far and large, the biggest cause of non-cardiogenic pulmonary edema is acute respiratory distress syndrome, or ARDS, or trauma. Pretty much ARDS is trauma. Trauma causes ARDS, which causes pulmonary edema. If you get stabbed in the chest, that irritation, that trauma will cause liquid and fluid to bleed or to permeate through your vessels into the surrounding lung tissue. And by far and large, some of them will then make its way into the lung itself and then cause you pulmonary edema. And another problem that occurs is when you get stabbed or when you have trauma to your lungs, the body then sends these lovely things called macrophages, and the inflammatory process starts. The inflammatory process causes cells to die, causes things to die, and then causes fluid to build up. So there's all these things that occur at the cellular level that causes pulmonary edema just from one injury somewhere that might cause a whole body response. And so, by far and large, pulmonary edema is the result of inflammation. Yeah, I did spend a good 5 minutes on this. It's my only joke for today. I'm sorry. All right. Pulmonary edema is the result of changes to your hydrostatic and oncotic pressure. Very briefly, the hydrostatic pressure is the pressure that is exerted on the vessel wall. Any closed vessel, any closed container with fluid in it will have hydrostatic pressure, pressure outwards. The oncotic pressure is the pressure of osmosis, where inside the blood vessel itself, we have proteins. In particular, for example, we have things like proteinase, we have things like amylase, and all these other proteins that are quite heavy. And so what that does is, because they're quite heavy, they're quite dense, the vessel wall itself will draw in liquid because the concentration of fluid inside your blood vessel is lower than outside. So there's a drawing of fluid inwards, and that's what we call the osmotic pressure or the oncotic pressure. And these pressures will balance each other out, the hydrostatic pressure going out and the osmotic or the oncotic pressure going in. There is some leakage of hydrostatic pressure. So the hydrostatic pressure will leak some stuff out, and that some stuff will leak into the interstitial fluid, but your body is very capable of removing that fluid very quickly via your lymphatic vessels or your lymphatic channels. So for the most part, pulmonary edema should never happen. It only happens when there are changes to these three permeability, so these three factors. Capillary permeability is how leaky something is. So if your vessel is really leaky, then you might leak a lot of water, and you might leak a lot of things, which will change your hydrostatic pressure, which will change oncotic pressure, which then causes pulmonary edema. So these people often have some genetic problems. For example, alpha-1 antitrypsin disease or deficiency is a disease that's commonly reported to cause a lot of pulmonary edema. It's a lifelong problem. Medication can help, but for the most part, these people just have very leaky capillaries. We'll move on now, to pulmonary edema from a cardiogenic cause. So pulmonary edema, cardiogenic cause. This is the heart. So what happens is there is something wrong with this chamber. This chamber is the left ventricle. The left ventricle can be damaged via, congestive heart failure, disease, drug abuse, you name it, all there. Blood builds up in this level here. Then blood builds up here. Remember what I told you? If there's a buildup, there must be a compensatory effect. So the blood just builds up behind it. All right. So blood builds up in the right atrium, so left atrium, and then blood builds up here, and then blood builds up over here. So this first arrow here, the third arrow here, blood builds up in your pulmonary veins, and your pulmonary veins then obviously build up over here, which is at the level of the SPL. At this point, we would call it pulmonary hypertension. There is an increase in blood pressure of your pulmonary system, and this patient might actually have systemic hypotension, as in their body blood pressure is not as high as it should be. So there's a buildup of blood at your SPL level inside your red vessel there, which is your pulmonary veins. That gets really large. When that gets too large, you have what we call interstitial pulmonary edema. The SPL itself, the interstitial surroundings around the SPL get really, really full. When that gets really full, it fills the inside. Then you have what we call alveoli pulmonary edema, and that's what we call the classic bat shape appearance on your lung x-rays. All right, so the enlargement of the pulmonary veins, remember, is a buildup of your pulmonary system, pulmonary hypertension. So your body is very smart. On a normal chest x-ray, again, from top to bottom, should look symmetrical, except for the appearance of your pulmonary vessels. Your pulmonary vessels are dependent on gravity and dependent on location in the lungs. Because the pulmonary vessels naturally travel south, they have more gravity potential going down, and because they're lower, they're fatter. So the vessels at the bottom of your lungs are fatter than the vessels at the top of your lungs. That is standard and normal. However, when you have pulmonary vein enlargement or engorgement of your pulmonary veins, your vessels, which aren't normally visible on a chest x-ray, become visible. So this is not a very good example, but can you see on the right-hand side there, you can see this blue arrow here on the second panel is pointing to this vessel, which wasn't visible here. It's getting larger. And can you see the red arrows here? It's pointing to the vascular pedicle. The vascular pedicle will enlarge, because what enlarges? Your pulmonary artery, because it has to enlarge to accommodate for more blood because there is pulmonary hypertension. So that gets larger, and so your entire pedicle gets larger, which is standard as well. This process in which the upper portion of your lungs, or the vasculature in the upper portion of your lungs get larger, is called cephalization or recephalization or engorgement of your pulmonary vessels. When the pulmonary veins can no longer accommodate that much blood, the blood then fills, so the liquid in the blood fills your interstitial surroundings of your SPL. The fluid leakage into the SPL will reduce your pulmonary hypertension. The reason why it reduces your pulmonary hypertension is because the volume of the blood is no longer the same if it starts leaking out. And this is the body's way of trying to maintain homeostasis, okay? And this is what we call the classic curly B-line appearance. All of these lines here on an erect chest X-ray is the fluid. Remember, it's 3D structure, right? 3D structure. So the fluid that's now around this whole SPL complex has now dripped to the bottom because the patient is standing up. And we often see it at the periphery because that's where your pulmonary edema often starts, because your terminal bronchioles often are found in the periphery of your images, so of the lungs, sorry. And so when you stand up, these curly B lines, which are about 1 to 2 centimeters long from the periphery, is an indication of interstitial pulmonary edema. All right, so the last bow is when the interstitial fluid itself can no longer be contained, and then the next venue is into the alveoli. Now, into the alveoli itself, and then hopefully your body will then cough it up as mucus. And that's how diseases work as well. You catch something, it gets shoved into the alveoli, and then you will cough it up, which is the body's way of expelling unwanted material. So now there's actually coffee inside of this. So this is inside of this is now the alveoli, and the alveoli contains all this interstitial fluid. This interstitial fluid doesn't naturally migrate up the of the bronchioles or into the bronchus because it doesn't have any force. It just sits there. There's no natural force pushing it up. It just wants to sit there. So a good hallmark of pulmonary edema and any form of real consolidation, because remember, pulmonary edema is a form of consolidation. Consolidation, by definition, is when the air inside the alveoli sacs have been replaced with some form of thing, right? So this is now consolidation, pulmonary edema, whatever you want to call it. A hallmark sign of consolidation is an air bronchogram, which we'll talk about in a second. Air bronchograms is because the actual consolidation doesn't travel up the bronchus very easily. And so there's still air inside the bronchus, which gives us an indication that this is a form of consolidation, but in my example, pulmonary edema. And you can see here, can you guys make out these lovely black lines throughout all of these pictures? This is an air bronchogram, and all the way to the edge, you can see curly B lines too on the periphery. This is a classic textbook example of pulmonary edema. Pulmonary edema is a bat wing-like appearance, starts the periphery and converges into the hilum, because that's how your bronchus works. It has to travel along the bronchus, right? And once it gets into this space, it becomes very prominent and the patient can rapidly deteriorate. So make sure that we keep an eye on these patients. If you see something like this, please make sure you tell a radiologist. So I'm just reading some of the comments. I'll answer some of these in a second. I just want to continue this for a little bit longer. All right, so chronic obstructive pulmonary disease is the second type of disease that I want to talk about. It is an umbrella term for two processes, and they are often emphysema and chronic bronchitis. These two diseases is our example is the two common examples of chronic obstructive pulmonary disease. Today, I would like to talk about emphysema. Emphysema, by definition, is an imaging diagnosis, and a chronic bronchitis is a clinical diagnosis. You don't need imaging to diagnose bronchitis, but often you will use imaging to diagnose emphysema. And by far and large, the most common cause is our friend, the cigarettes. So if anyone knows anyone that smokes, and if you can convince them, they should stop smoking because they probably have emphysemic changes. A classic sign of a person with emphysema, if you don't know, is what we call the pink puffers. Because the emphysema in the lungs causes them not to be able to breathe properly. And I'm trying to word it very carefully so I don't give away all the answers for later. They don't breathe in or breathe out very well. So to be able to breathe, they often pass their lips and breathe in and out very gently like this. And the reason why they do that is because of pressure changes inside of their chest due to emphysema. And so over time, their face becomes quite pink. And anyone that knows anybody with emphysema will know they're probably underweight and they're probably quite tall and narrow. The reason is with all that extra energy spent on breathing, thinking about breathing, you just lose so much body mass and body weight due to all that excessive energy usage. Okay. Chronic bronchitis, on the other hand, is, you may hear the term blue bloaters, which is often clubbing of their fingers and the face is quite blue, cyanosis, that kind of stuff. And there's a reason for that. But again, because I'm not talking about it, something for you guys to research. Blue bloaters. Okay, we'll move on to OneNote again. Okay. All right, let me answer some of the questions on the chat first before I move on. Great point to know. Swangans. I haven't actually heard of this one before, but if it is a true central venous catheter, then they must end at the sinoatrial junction. We do have what we call midlines. Midlines don't end there. They end somewhere there. Midlines are often used for short-term use and they're less prone to infection, but for the most part, central lines are safer. Can you explain the first question from Menti? The left lung situates more posteriorly. Oh, yes, that is coming. One of the questions was, can I explain why the left lung sits more posteriorly? I'll explain that in a second. And perfect. All right. Now back to OneNote. And I can guarantee I am going to be running over time. I've got another PowerPoint after this still. I talk too much, I'm sorry. All right. Again, I've taken the liberty of drawing some pictures beforehand. All right, emphysema. How does emphysema work? Emphysema works because there is some thing that causes a destruction of your arsenis, and the alveoli are destroyed. So this is the SPL, arsenis, etc. So this lovely appearance that you normally see in your arsenis is destroyed. So it becomes this singular circle, for example. And can you see how, as I'm drawing this, the red lines become more and more prominent and more closer? And that is a hallmark of emphysema. It starts very locally, but then what happens is over time, it starts destroying itself. And it starts destroying itself more. Oh, terrible drawing. Okay. Sometimes it may only start in one location. Maybe it might start here and it might start here, but then it might go here. It can be random. That's very normal as well. And what happens is when you destroy all of these grape bundles, your arsonists, what actually happens is that you lose the ability to exchange air. When you lose the ability to exchange air, you have problems, okay? And we'll explain them further down here. Okay, so you're probably thinking, Hong, how does emphysema actually cause destruction of your arsonist? Well, the actual alveoli sacs, if you zoom in with a magnifying glass, with a microscope, I'm really struggling today. I really need more coffee. If you zoom in, you'll see that it's actually layers of cells. And what happens is some irritant goes in. This irritant could be smoke, could be disease, it could be asbestos, it could be God knows what. And what that does is this irritant sends these, I wish I was a good drawer, sends these things called macrophages in. These macrophages come in, and what they do is they try to remove this process, but this smoking problem causes these macrophages to stay for a long time. So what happens is this smoke kind of coats all of the cells and stuff. And so what happens, the macrophages start getting really annoyed at this irritant, and it causes this inflammatory process. And what happens is you lose this beautiful coating. And once you lose that beautiful coating prevents destruction to the actual spaces in which air is exchanged. And that beautiful coating also has things like elastin and things that help keep structure. So now this particular vessel no longer has a structure. And because it doesn't have a structure, it's more easier to damage. So this red outline is actually the blood vessel, all right? So it's an inflammatory process. I can never pronounce this word. It's an inflammatory process which damages the alveoli due to an external stimulus. So the resulting problem is that you don't have the ability to exchange air properly. So now what happens is originally we might have had 1, 2, 3, 4, 5 areas to exchange air, and now it might only be 1 or none, right? And so this CO2 waltzes past at high velocity, all right? High velocity. And the problem with this is because there isn't a lot of space now for the gas exchange to occur, there is less O2 inside of your blood, and therefore you have hypoxia, a decrease in oxygen in your blood because the gas exchange isn't possible. So what do? Your body naturally thinks the problem is you're not breathing enough. So then they start forcing you. Your body starts hyperventilating, go to try to breathe. But the problem with people with emphysema is that they're not able to do that properly anyway, because the actual destruction of that beautiful coating inside of your alveoli sac will now prevent your body from even doing the bare minimum properly. Okay, so what happens is, according to our laws of physics, right? And I just realized I didn't draw it, so I'll draw it down here. Is our law of physics says this: if we have a vessel, right? This is our vessel, and this is our blood vessel. It's going this direction, or that direction, doesn't really matter. And there's meant to be a gas exchange. O2 going across. But the problem is there is no O2 going across. So what does your body do? Your body exhales to try to get more air in because it's thinking, oh, you're not exchanging enough air. Therefore, you're not breathing enough. So therefore, let's breathe harder, right? So your body goes, crap, breathe out and breathe in again. So you breathe out. You've lost a few things. You've lost that beautiful coating in your cells. That beautiful coating has a few things, but one of the most important thing is elastin. Elastin is a protein that helps with the elasticity of your bronchioles and to help them close and expand and to keep shape and that kind of stuff. So what's happened is that air that runs at high velocity has a very low pressure behind it. That low pressure causes the cell to close, but the elastin often keeps the bronchiole open, right? So air rushes out because you've breathed out, because the body is going, oh crap, you haven't had enough oxygen. So it goes all the way out. And normally the Bernoulli principle says that when air goes forward, there is always an air of low pressure behind it. So that low pressure sucks in the cell, sucks in the bronchial wall because of the low pressure. The elastin inside of your bronchiole will prevent that collapse, keeping the bronchiole open, right? But because you don't have elastin, this is what happens. A very narrow opening now. So air has tried to come out. This low pressure area here has now caused the bronchiole to shut on itself. And therefore you have what we call the hallmark of emphysemic changes, air trapping. Air trapping is the result of destruction of the bronchiole and the actual alveoli areas, which now prevent it from maintaining its shape. It's easier to collapse. So on expiration, that change of pushing air out causes the area behind the air to become a low pressure region. The low pressure region sucks in the walls of the bronchiole, closing off the exit, and therefore air stays inside of the arsonous region, the emphysemic region. And over time, this constant air trapping will make the emphysema bigger and bigger and bigger. All right. So there's a couple of other compensatory effects that will happen as well. The body is pretty damn smart. If it knows this SPL here is buggered, right, it will pretty much vasoconstrict, okay? And it'll prevent a lot of blood from reaching that area. And then it will vasodilate the other vessels. And for the most part, someone with emphysema may not know they've got emphysema until chronic emphysema occurs, because what happens is after time, if more and more of these SPLs become non-functional or their function is reduced, all of these vessels shut up, or close off, sorry. And so what happens is, where does the blood go? Well, up. The blood has to go up, or it gets backed up, I should say, into the pulmonary artery. And if it gets backed up into the pulmonary artery, back to our beautiful heart. This is the pulmonary artery, right? Well, then it backs up into here. If it backs up into here, then it backs up into here. It backs up here and it backs up here. So this patient might have a couple of things. Well, if it backs up into the heart long enough, it might have what we call cor pulmonale. I can't spell pulmonale, I can't, in there somewhere. And it might cause portal hypertension. Because where does this blood go? This blood in the IVC goes to the portal vein, right? Or so it goes to the liver, sorry. And so, you know, you might have a few things happen. So chronic hypoxia, which means chronic emphysema, will lead to increased pulmonary vasoconstriction, which will lead to pulmonary hypertension, and then it will lead to cor pulmonale, which cor meaning heart in Latin and pulmonare meaning lungs. So it is a result of lung and heart not functioning correctly. Pulmonary edema, which is usually the result of the left side heart strain, is very similar. It also causes pulmonary hypertension, but different. It's not a heart problem. So it's not a lung problem, sorry, it is a heart problem. All right. Now, briefly, finally, images. Just very quickly, this is the same image you saw before. It is a normal chest X-ray. You can see lung markings all throughout the lungs itself. And you can see that the bottom of the lungs here have pulmonary vessels that are fatter than the top. All right. And you can see lung markings all the way to the edges of your lungs. If you move down, now this is an extreme example of emphysema. Now, can you see the flattening of your diaphragm? This is a fine example of overinflation of your lungs. You should have this, normally it should be this shape, a nice curvy barrel shape, but you don't have that. You also have, let's see, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 posterior ribs and the beginning of 12 posterior ribs. This is an overly hyperinflated lungs. The lung vasculature at the top here is dense, which means there's been some engorgement. You can also make out some areas here which kind of resemble cell-like structures. It's a bit hard, might be hard to see on your screen. And this is an example of emphysema. Okay, this patient has emphysema. All of these changes on the right-hand side here is coupled with a pleural effusion as well. So left-hand side, sorry. Now, unfortunately, my OneNote has capped it, I think, because these circles shouldn't move. So we'll just ignore that. Luckily, we're almost finished. So ignoring the circles, this chest, lateral chest, the retrosternal space, which is the space in here, is very large. The retrocardiac space here is also very large. There is a lack of vascularity in both of these spaces. You have a very flat diaphragm and very little costophrenic angle, and the AP direction, the anterior post direction, with respect to the bottom, is very large. So this is what we call a barrel chest. Again, a hallmark sign of emphysema. I'm so sorry, all the lines have disappeared. Good. Another example of a barrel chest, the retrosternal space here, and the retrocardiac space is quite large. You can see a very, 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 very flat diaphragm, zero costophrenic angle there. And if you have a look at the lungs, you might make out some small density changes in there. Okay, again, an example of emphysema. I have some CTs here. This is an example of a high-res CT. Now, this is an example of central lobular. Now, you can make out some structures here, for example. Now, that there's a vessel running right through the middle of it. Now, that is probably synonymous with my coffee cup and my pen going through the middle there, through the middle of it. And we've just taken a slice right through the top there. So you see part of the vessel and part of the emphysemic changes. So this is what we call central lobular. Now, these are this is more progressive. The middle picture is more progressive. You start losing more and more normal lung tissue. Can you see how this is one big vessel here? And then these are little vessels that branch off, but you don't really have lung tissue. It's just vessels and black emphysemic changes. This white appearance that you normally see in lung isn't there. And then, of course, these ginormous paraseptal emphysemic changes here as well. All right. So that should probably say back to Menti. Are there any questions so far? Wow. Okay. All right, quiz time. A couple of quizzes to break the mood a little bit. I know I've gone through a lot, but hopefully you've got something out of it. Oh, didn't fix this up. What is your diagnosis? There's at least a tracheal deviation. There is pathology in one side, two sides, portable done, lines everywhere. There must be an ICU at least, or in resus, the very minimum. Well done. You guys have made me proud. Well done. It's actually a pushing pathology, right? Pneumothorax, 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 pneumothorax. Could be. All right. So you can see it's a tension pneumothorax. The right side is completely void of any lung markings. You can actually see the lung squashed in the bottom right corner here. Tracheal deviation completely towards the left side. Left side is overinflating with lots of increase in vasculature to compensate for the lack of vasculature on the right. An example of a tension pneumothorax. Oh, and please tell me that, sorry, make sure that when you see these kind of examples that you tell a radiologist immediately, or the nearest emergency doctor if you work in emergency. Is the CVC in an appropriate position? The answer is yes. Now, this actually brings up a good point. Depends on who you ask. You may actually get different answers. Some doctors may not be as comfortable using a CVC that is slightly lower than someone else would be comfortable with. But I think in this example, it looks a little bit low, but in my experience, most doctors would be quite comfortable using that. That does look like it's in the sinoatrial junction. And if it's not, you will find out very quickly, because the patient will go into atrial fibrillation and they will probably need a line retraction very quickly. Now, the reason why I've brought up these two images is that these days on a mobile machine, you have the traditional chest X-ray, which is on the right-hand side here, and the left side. What I want to emphasize is, if you can't see the central line or an NG tube or whatever tube that you've done, don't repeat the images straight away. With the new advances in technology, I advocate the use of common sense. Use every single technological technique available on the computer. This software, and pretty much every vendor has some form of tube and line check algorithm, has made the line much more visible, okay? This image on the left is the same patient on the right, no extra radiation. It's a bonus complementary picture. Why wouldn't you do it? All right. Please make sure you don't repeat the x-ray just for the sake of repeating the x-ray. Check to make sure that your software isn't able to do it for you. And secondly, if you use the correct exposures, you shouldn't have a problem anyway, right? All right, next quiz question. Is this line tube in an appropriate position for use? I want 100% success on this one, please. The answer is no. The tube is not in an appropriate position for use. Do not ever use this. If you see this, you pretty much tell somebody to pull the tube out pretty quickly, because what's going to happen is if that tube is left in that position for too long, you're actually going to block off the airway on the right side. You're going to cause atelectasis on the right side. You're going to cause consolidation in the left, because the left side will need to revascularize to compensate for the lack of the right. The NG tube has gone down the right main bronchus. Also remember that the right main bronchus is actually often the most commonly incorrectly inserted direction. The reason is the right main bronchus is more vertical with the trachea, and so a misplaced NG tube often slides down the right side as opposed to left. However, the left is possible. Just please make sure you review your images correctly. This is a medical emergency. It must be notified to a medical practitioner immediately. All right, so next question. Name this pathology. Now, this is a hard one for the first years. The first years may not get it. Hopefully the fourth years and others can get it. You guys have made me so happy today. It's good to see that many people are getting the answer right. You know, there's nothing wrong with getting it wrong as well, as long as you can recognize it now and do it right next time. All right. So you can clearly see there that although you can see the diaphragm, you can actually see this bulbous meniscus sign as well. So therefore indicative of a pleural effusion in the right side of the patient. All right, let's see. Jasmine Simon didn't hold their lead. So Yomna is the leader. All right, so just very quickly, I know I'm running over time. After this Menti presentation, I do have another one. And if you don't want to stay, you're welcome to leave. I am determined to finish it off. So you're welcome to stay for longer if you like. Two most important radiographic signs. An air bronchogram, my favorite word, air bronchogram. You in the old days, by they I mean our supreme leaders and teachers, our older radiographers would participate or even perform barium or bronchograms because CT wasn't available. And so they were horrific things to watch and do, apparently. So these days, we're very lucky that we only see air bronchograms. So, air bronchogram. This picture has this example has a lot of things going on at the moment. Right. So, yes, and James mentioned a drownogram as well. Yes, my supreme leaders have always mentioned that you often need to have a physiotherapist ready when you do a barium bronchogram, because they often will drown because you are literally drowning the patient. So they'll do percussion to try to pat the barium back up, and they will vomit a lot to try to get it all out. So there's a lot of things going on here. The patient, the history of this patient, from what I can recall, and I can pretty much guess, must be some form of trauma or accident. They must have had some form of motor vehicle accident. This just looks horrific. The arrows are pointing to something important, and that is air underneath your heart. Normally, your diaphragm will touch the heart, and so you're unable to differentiate the bottom heart border and the diaphragm. But because of the air, you can see it now. And this is what we call a continuous diaphragm sign, or an example of an air bronchogram. And this patient has pneumopericardium. You can see that very nicely on the CT, but all of this stuff here in the shoulders and neck and all of this stuff is surgical emphysema or subcutaneous emphysema. And this patient has got a lot going on. So they must have pierced a few things. They must have pierced a few lung components, and it's just leaking everywhere. If you ever work in a trauma ward and you come across these patients, one of the things you will hear people say is that they have a crackling sound because the bubbles and stuff inside the skin is constantly popping and re-emerging elsewhere, because every time you touch it, the air dissipates and that makes a sound. So there's this crackling noise. This patient just needs a lot of steroids and a lot of tender loving care, to be honest. There's a lot going on here. And I think I was supposed to come to this slide to describe the words, but we'll move on because I think you guys have heard all the words that you can imagine. So the silhouette sign, again, similar to the air bronchogram, when two structures with similar densities are next to each other, you're unable to differentiate them just purely because the densities are so similar. So because of that, we know that they must be touching each other. If there is a smidgen of air through that interface, so structure, another structure, and there's air between it, you should be able to differentiate it on chest x-rays. This example with all the arrows pointing to it, and hopefully you can see the mass, there's no distinction between heart and mass. And so they must be touching. If they are touching like this, and it's against the heart, it must be an anterior mediastinal mass, right? If you see an anterior mediastinal mass, you think of 5 T's. This is a little catch mnemonic that you can think of when you think of an anterior mediastinal mass. 5 T's is always going to be thymic neoplasm, teratomas, thyroid origin, terrible lymphoma, and a thoracic aortic aneurysm. All of these can appear like a mass or something is abutting or touching or engrossing upon the aorta. By far the most common is terrible lymphoma. Lymphoma spreads to that region quite easily because it is a lymphatic spread. So carcinomatosis lymphangitis. And so it spreads in that general direction. And so lymphoma is quite common. For the younger cohort, teratomas is quite often quite common. For the older cohort, you might get aortic aneurysms, And for the mid-age, it's usually between lymphoma and thyroid origin. All right, so what next steps would you do for this particular patient or any patient with that kind of disease? You would often employ a PET scan. Again, for the same reasons, you want to know whether there is metastatic spread elsewhere, whether there is FDG avidity elsewhere. You want to make sure you know the extent of that mass. So that mass that we saw was quite large, but is that mass large and active throughout, or just active on the periphery? As a lesion gets bigger and bigger, the insides normally starts to die off, becomes necrotic, because the blood supply that it has stolen is no longer able to sustain the whole lesion. And so often the inside is quite necrotic. And this is also another way that we can check to see if treatment is working. A lesion may not shrink in size, but it may shrink in activity. So that's what you might hear in the media. My PET scan lit up like a Christmas tree, or they couldn't find any activity. That's because a PET scan, it looks at the physiology of the patient to see if that lesion that they're targeting is active or not. All right, so another example very quickly, you can see here there is no real distinction between this lesion and the mediastinum. Therefore, the lesion must be inside of the actual mediastinal compartment. This kind of vicinity, I would suspect it probably be like a lymphoma or a thyroid origin as well, or a thymic origin, sorry, thymic or a lymphoma origin. This one though, can you see how, although I can see a mass in the left side here, I can still make out the heart border. So I know that this structure, due to the silhouetting of our images, must be more posterior or more anterior than our heart. But because I can actually make out the anterior portion of our aorta here, the ascending aorta, so descending aorta here, this must be a posterior structure. Now, I'll have to explain it later. I didn't realize I didn't put another lateral image of how the silhouetting works. I can actually explain it. The silhouetting on the lateral, where I told you that the blue line was the left side, was because the left diaphragm touches the heart very well. Because there's not usually an air interface between the heart and the diaphragm, on the x-rays, you often aren't able to differentiate the bottom heart border from the diaphragm itself. So what happens is, all you see is this diaphragm will end at the heart border in the retrocardiac space. And so what that means is that must be your left diaphragm, because the rest of it, which is there, but you can't see, is currently underneath the heart, touching the heart. Now, all right, consolidation is not air. This is pattern number 2. Nothing very exciting to talk about. Again, it is an umbrella term, hence the umbrella picture. And this is an example of consolidation. And you've seen it before, pulmonary edema, consolidation, stuff that fills the alveoli sacs. You can see some air bronchograms here with these black things. That means there's air there, and there is soft tissue interface on either side. If you don't have things on either side of air, you can't see the air. Consolidation is not atelectasis, because atelectasis by definition is a reduction in volume. Consolidation does not cause volume loss. Okay. And as I mentioned very early on, sometimes it's just not possible, or within your own expertise level, you don't know what to call it. Just call it a white, hazy opacification in the left upper lung, right upper lung, lower lung, middle lung, singular, bilateral, has air bronchograms. I think it might be this, but I'm not quite sure. Okay. All of these pictures look somewhat similar, but they're actually caused by different things: pneumonia, pulmonary edema, heart failure, etc., etc., etc. So from experience, you could probably tell what they are, but don't stress too much about it. So the take-home message today is chest x-rays should be comparable left to right, should be comparable the same level. Think about, is it a push or pull pathology? Atelectasis is less aeration, and consolidation means there is no air. Now, that is the end of the first part of the presentation. I have gone overboard again. However, you are very welcome to head off if you don't want to stay for the image critique bit. But if you want to stay, please feel free. I will proceed straight away. Are there any questions at all? I will still be using Menti to ask the questions, or you can ask in the Zoom chat, I don't mind, but just make sure that you follow up on it in case I don't read it. All right, so I will continue then. Actually, what I might do before I do that is I'm just going to put up the attendance part of the Menti presentation again. The same code, just so that anyone that hasn't filled in the attendance can still do it, just so that they can get their CPD certificate. So for those who want to fill it in, it should be available now on your screens. All right. All right. Chest radiography, evaluation of chest radiographs. I am going to go through this relatively fast. A lot of this should be familiar to all of you, but I'll make sure that I take questions when I need them, okay? All right. So there are a couple of things that I would like you guys to remember whenever you're evaluating your chest x-rays. Look for rotation, penetration, inspiration, magnification, and angulation. I will go through them now. Adequate penetration. The words we often look for, is it underexposed? Is it overexposed? All right. Now, a key concept of penetration is that in the textbooks and in most books, it will say that a chest x-ray is adequately exposed when the thoracic spine can be clearly seen behind the lower heart shadow. So between like T6 to 9, if you can see those vertebrae through the heart, most people would consider this an adequately exposed chest x-ray. Under penetration, in this example, the left hemidiaphragm is not visible. And this artifact can cause diseases to hide itself. Because we've underexposed the images, sometimes the extent of the disease is exaggerated because pneumonia and other consolidative findings look white on our images. And we've underexposed, so therefore, overall, the image is whiter. And the pulmonary markings could appear more prominent. Remember what I told you before? We look for things that are changes in the compensatory effects. So engorgement of a vascularity, so congestive heart failure, pulmonary edema, all those things enlarges our pulmonary vasculature. So if we underpenetrate our x-rays, our images can look quite white, and therefore the actual vessels can be quite enlarged, can look enlarged, sorry. So this example, I think I've explained it relatively well. There are a couple other things that we'll talk about later regarding inspiration and that kind of things. But overall, if you look at this image, it is very white. It's not pleasing to the eye. It is very underexposed. And if this was a true exposure, you could think that the patient has some form of lung pathology that's causing a lot of hazy appearance throughout their lungs. Now, don't get me wrong. When we look at an image, if you are satisfied with your images and you can tell yourself, this is an adequately exposed image, the exposures are correct, everything is correct, then what you see must be pathology. But in my experience, this is a very underexposed image. Something needs to happen. It has a mottled appearance as well. Now, over-penetration is the opposite. If an image is overexposed, the lung markings may not appear, and it gives this very burned out appearance. When you over-penetrate, you increase the exposure factors in such a way that you start burning out the least dense structures. In the chest, the least burned structures is your lungs, then your soft tissues, then your heart, then your rib cages, and your thoracic spine. In your hand, for example, the least dense structures are your soft tissues around your hand. And so that's often the first place you look. Can you see soft tissue margins? Yes, I can see soft tissue margins. Therefore, it is an adequately exposed hand X-ray. Oh, I can't see these soft tissue margins. It's completely black. Therefore, it's an overexposed chest X-ray. Therefore, something is too high. We'll go through that in a second. I've on purpose omitted a certain word in that statement. And of course, as I mentioned before, in the previous Menti stuff, a dark lung is usually an indication of emphysema and pneumothorax. So we could cause the wrong diagnosis. But again, fortunately, if it's bilaterally dark and it looks really dark, then you could say it's an exposure problem. But if it's only one side, then it must be pathology. It can't possibly only be one side. It's impossible. Now, this is overexposed, over-penetrated, and you can see that the first place that we start to lose information is your lungs centrally, and then it works its way out peripherally, and then you'll start losing your soft tissue as well. We could try to window or to manipulate this image to bring it back to acceptable viewing levels, but for the most part, this may not be possible because the center of your image has received too many photons that the actual information is so lost inside those pixel values that the computer won't be able to demonstrate this as well as it should. But of course, I advocate proper radiographic technique, learn your exposure factors, know your equipment. Not two equipments are the same. What you learn in one clinical center may not apply to another clinical center. And even within the same clinical center, what you use for one room may not be the same for another room. So make sure you're well aware of the limitations of your system. Quantum model is in a nutshell, and these notes are available on my website, but you're welcome to read them. In a nutshell, quantum model is the lack of information, and because of that, we have noise. And quantum model is the result of a lack of photons reaching the detector effectively. I won't read through the notes, but quantum model is the result of exposing a large area with insufficient photons. So when we select the exposures for the examination, we want to minimize this effect. Therefore, it is imperative that we observe patient size and distance from your patient to your source. So if the patient is quite large, then you need to increase your exposure, because what's going to happen is a lot of your photons will be absorbed by the patient, be attenuated by the patient, and so it won't reach the detector. Because it won't reach the detector, when the detector calculates the image, it does a lot of averaging, and then it causes this effect called a quantum model. It's quite grainy, quite noisy. Okay. Then I have an analogy. We'll move on from the analogy. All right, adequate inspiration. Inspiration, I think, is pretty stock standard, shouldn't be difficult for you. The degree of inspiration can be assessed by counting the number of ribs. We usually say 10 posterior ribs above the diaphragm is good. And then 8 to 9 posterior ribs is usually adequate in a hospital trauma setting. I wouldn't expect someone that has gone to surgery and the next day they're asking for a PA chest x-ray to do a solid 10 posterior rib breath in. It would be nearly impossible. And usually 6 to 7 anterior ribs above the diaphragm on a good inspiration is also acceptable as well. Poor inspiration will compress and crowd the lungs. It will give an impression of consolidation, if you like pneumonia. And if more ribs are available, then the patient has hyperinflated, and diseases like emphysema and those kind of things might be more easily diagnosed. Just remember that we need to coach our patient really well as well. It's all and good if I say, breathe in and hold your breath. But if you haven't told the patient, in a second, I'm going to ask you to breathe in and hold your breath. What I want you to do is take a good breath in, a solid breath that you would normally do, hold it in your chest until I tell you to breathe out. Then the patient might do this. They have breathed in and they're holding it, but they're holding the end of their breath. And it's not a good inspiration. A good radiographer coaches your patients adequately from start to finish. A good radiographer watches your patient to make sure that they have good inspiration effort, okay? And if they don't really understand, then make sure you practice. Sometimes practicing is all it takes to make sure that you give them a solid, good breath in. Counting ribs, I've mentioned before that there is 10 posterior ribs often and 6 anterior ribs. Anterior ribs are often easier to count at the top. So the number 1 here on the left side, if you bring it back, that is the first posterior ribs here. Number 2 is over here. If you bring it back, that is the second posterior ribs. And then I often count 3, 4, 5, 6, 7, 8, 9, 10. Because I often find it hard to judge where the posterior aspect of ribs 1, 2, and 3 are sometimes. So then I count the anterior ribs and then I count the rest posterior ribs. Patient rotation, look at your clavicles to make sure your clavicles are equidistant from your spinous process. This is relatively easy if you do a PA chest. Just make sure that when you stand them up, if you need to, get them to wriggle a little bit to get all their jiggles out, and that often gets all their chest muscles to relax, and then you can see if they're twisted one way or another. And for a PA, you really shouldn't have any rotation. It'd be very difficult to have rotation on a PA. On an AP chest, though, it is more likely. My recommendation is to get them to lean forward and then wriggle again. Get all their shoulder muscles relaxed. So when they sit back, they're not like twisted on one side or another. And that will help you. Another thing you should try to do with your AP chest is to stand directly in front of the patient. If the patient is in a hospital bed, then just if you find it too difficult to turn the patient, just turn the bed. So then the patient is physically moved into position so that they are parallel with the detector and perpendicular to your central ray. If your central ray is hard to get it to align properly, then move the patient, whatever's easier. But always stand in front of the patient, dead center, and make sure that you look to make sure the patient isn't rotated. For example, this is how to assess for rotation. The green and purple stars indicate the patient's clavicles are parallel, I guess, with the detector. If the left side of the patient is closer to the detector, then your left clavicle moves closer to the spinous process, because the spinous process is now here. All right, so the clavicle is almost projected direct on top of the spine, and the purple is projected away from the spine. Because remember, we're still imaging in this direction along the vertical black line, and conversely, the same with the other image. If you were doing rib views, this is fantastic. But if you're doing a chest X-ray, you really have to try very hard to get a PA chest to be rotated. So please just be a bit more observant of your X-rays if you cause rotation in your PA chests. Assessing rotation, this is just the continuation of the previous example. You can see how the stars are projected closer or further away, depending on where it is that we are imaging. On an AP, it is reversed. So remember, if you're going to get anything out of today's presentation, remember Hung's euphemism, AP away. So AP is the side that it is away from the detector. That is the side that you are imaging. So in other words, if you're doing rib views, if it's APS away, the left side is the side that you're imaging, and that is the side that's rotated, okay? Image magnification. An object that is closer to the image detector will produce a more faithful representation of its size, contours, and position on the resultant radiograph. An object that's further from the image detector will be magnified. Okay, so that is why we always do a PA chest, because the heart is an anterior structure, and so we get a better representation of the size of the heart. A better representation of the size of the heart helps us determine lots of things like heart size, cardiac related diseases, etc., etc. Technical factors can also contribute to magnification or minification. A normal chest X-ray is produced at 180 centimeters FFD or SID, and that is the standard that we base off in Australia. Due to the ceiling height, if you perform a supine chest X-ray, you can often only go to 100 to 120 centimeters. The closer your source is to your patient, or the closer the source is to your detector, the more magnified your images are going to be. So if you can help it, avoid at all costs doing supine chest X-rays. You don't have enough FFD to have an adequate FFD to produce a somewhat faithful image. So if you look at this image here, A and B is just an example of AP and PA. You can see here how the heart size of A is a little bit smaller than the heart size of B. And that is why often on the radiology report, you might see the radiologist write, because the image is AP, heart size is not accurately measured, but considering even the projection, heart size looks normal, etc. Now, this is the supine ceiling restrictions. You can see how, because we cannot obtain an adequate FFD, we're unable to replicate the example of A in B, although the divergent angle of the beam is the same. Just be mindful of that. My preference always is to sit the patient up as much as possible. Even a semi-erect is better than a supine if possible. Of course, sometimes the patient is full trauma and you can't sit the patient up. Well, so be it then. You might need to do 2 X-rays, one for the upper half and one for the lower half. Angulation, the clavicles should be projected over the 4th to 4th rib. And if the angulation is not 3rd through to 4th, then you are either lordotic or kyphotic. This image is kyphotic. 2 things to consider. First thing, is this a patient presentation? If the patient is naturally kyphotic, then your image, even though you try, will most likely be kyphotic. To offset this, some textbooks or some institutions will do an AP chest, because then the patient can lean back a bit more. And so the kyphotic nature of the patient will be minimized. You can cause a kyphotic chest by overangulation. So if you are doing an AP chest X-ray, you can easily cause this to become kyphotic by overangulating. And to fix that, you angle less. You can make it quite lordotic by angling up too much. And to fix that, you angle down. To produce these images standing up, the only one that I think you might do routinely is the kyphotic nature. Females in particular, because of their breast, often don't have their chest perpendicular to the detector. When you get them to lean forward, their chest, their breast keeps them from leaning forward or in one plane. They kind of bend themselves forward. And so the top half is kyphotic, but the bottom half, due to their breast, aren't able to bend with the patient properly. So just be mindful of that. If I'm doing a female, I often don't get them to lean into the board. I often get them to be nice and tall, and that just helps prevent excessive kyphosis. This is a lordotic chest I mentioned before, either angling up. Sometimes in routine practice, you might produce a lordotic chest, sometimes to see the apices of the lungs, and sometimes as a second view for your clavicle projection, but you routinely shouldn't do this. So the take-home message is everything that you see there. Now, I have more to go through, so you are welcome to leave, and I'll continue on into OneNote. Any questions at all? Okay, very good. All right. So this is a very burned out chest X-ray. Because it's bilateral, you can see that all this stuff here is technical. And so this is over exposed. Okay. There are two factors which we must consider: our KVP and our MAS. Now, something that we need to consider is, what does MAS do and what does KVP do? Well, MAS is traditionally referred to as our density, and our KVP is traditionally referred to as our contrast. So if our MAS is too high, what does that do to our density? Our density is the density of the photons, how much photons are on the image. So if we increase our MAS, we increase our density. If we increase our KVP, what does that do? If we increase our KVP, we reduce our contrast. It's an inverse relationship. The higher the KV, the lower our contrast imaging. A fine example I can give you straight away is the chest. We perform our chest imaging at about 120 kV. For the same body region, for the rib views, we often do 60 kV. Why the drop from 120 to 60 kV? The reason is ribs, we need a high contrast image to see the tuberculations and the changes in our ribs to be able to produce a diagnostic image. So we know that if we reduce our KV, we increase our contrast. But by doing that, we lose penetration. So we just have to be mindful there is a balance between the two. Okay. So in this instance, the density is very strong. It's got a lot of darkness and a lot of white. So this must be a lot of darkness. So this must be MAS is too high. Now, in my experience, this image also looks quite gray. The bones are quite flat. The rib cage is quite flat. The thoracic spine is quite flat. So we could probably argue that the KV was a little bit too high. A little bit too high, okay? Because the contrast is a little bit low, a bit flat. It's not what I would expect, okay? Now this image, when we look at images, we compare an image in our, the image that we see, sorry, with an image in our head. The image in our head should be an optically beautiful chest X-ray, all right? However, if we were to say, let's just say that this is the textbook image. It's not, but let's say it is a textbook image. Then B, in comparison to A, is 1, underexposed, because it's too white. We don't see our soft tissue margins like we should. We see too much soft tissue margin. The shoulder blades all up here. We don't see as much in the shoulders, and we don't see our rib outlines like we should. We lose our thoracic cage outline as well, okay? So therefore, 2, the MAS was low, okay? 3, our KV was probably good, tick. The reason why it was good is because we can see our trabeculation. So we can see the trabeculations in some of our ribs, and we can probably make out a lot of our vascular markings quite nicely, okay? So our contrast is probably good, all right? But if image B, conversely, was the textbook image, okay, is now textbook, then image A would be 1, overexposed, because it's darker, it's blacker, there's more photons reaching the image, okay? 2, the MAS is probably too high if B was the textbook example, because to make the image more denser, to make the image darker, we need more photons, more MAS. 3, if B was a textbook image, then the KV is probably too high because we've made our image grayer. Image B is very black and very white. It's very contrasty. The trabeculation of the ribs are very defined. The vascular markings are quite prominent, but in A, those signs are no longer there. Therefore, the KV is too high. So in our head, we always must have what we call the textbook example. And that's what you often describe it as. This is a textbook example, or this is not a textbook example. All right. So an example of KV now. Again, let us use this one as the textbook. Well, right off the bat, we can probably say that 1, the exposure is adequate, because adequate exposure, because the thoracic spine is very comparable on both images. If the image on the left here is a textbook example, it's not, but if it was, then they're both comparable. So therefore it is adequate exposure. You're comparing one against the other. 2, MAS is probably adequate because they're comparable, right? 3, it is very gray. This image is much grayer than this image. You have less contrast in the second image than you do in the first image. So therefore, the KVP is too high. You've increased the KVP. Way too high. Okay. So if this conversely now was a textbook image, then image A is probably again overexposed because it's now, no, sorry, underexposed, whiter. The MAS is probably lower, and the KVP is probably lower, because you can see all of the lung markings much easier on your first picture. All right. I can't remember what I was going to say about this picture, so we'll move on. All right. So this is an example of 3 pictures at 3 different contrast levels. They call this optimal, I would argue, but let's just go with that. Okay, so this would be KV was good, low contrast, KV is too high, and high contrast, KV was lower. Okay, now this image, what's wrong with this image? Let's move away from our contrast and density. Let's talk about angulation. Your clavicles are way too high. Your ribs are very horizontal, sorry. This is an AP erect chest X-ray. So this is the patient. This is the patient in a chair, for example. And what's happened is the radiographer has put the detector behind their back, and the X-ray tube has been angled up. Okay, so you need to angle down. A good starting point that I always say for my lateral chest is that, so my AP chest, is that I always often angle perpendicular to my detector and then down 2 degrees. Okay. The reason is I find that most people in AP position sit quite leaned back anyway. So that if I angle to the detector and then angle down slightly, I will then be angling to the angle of the sternum, which is the correct way to angle for your AP chest. So I find my experience, they sit like this, detector is back, because they're leaned back, because they don't have a headrest normally, they're leaning back onto the detector. If you angle to the detector and then angle down a bit, 2 degrees, you should get a beautiful AP chest. Now, this image is hopefully very self-explanatory. I can't even make out your spinous process, but I think they're there. That's your spinous process. That is one of your clavicles. And I think the other clavicle's over here, actually. That's your other clavicle there. So clearly this is left side. Because it's an AP projection, you wouldn't do this PA with all these lines. So what's happened is, if you look at it from a top, this is their mid-coronal plane, and you look at it from a bird's eye view, what's happened is they have turned that way. So now they're facing this way. Okay, and that's how you get this orientation. And another way that you can find out is that your posterior left ribs are very elongated, and that means that they must be, because of the geometry of your chest, your ribs run down and outwards. So therefore, when you turn your chest with the ribs more closer to the detector, the posterior ribs will now be more horizontal and parallel with the detector. So you get beautiful posterior rib views. So the left side must be closer to your detector, if this was a AP projection. Hopefully you guys instantly see the lovely sail sign here, lobar collapse. I think that was really it, that one. And this one here, I wanted to mention the pleural fusion here, and I wanted to mention this here. Why does this occur? Why does this blackening occur? The blackening occurs because you haven't got everything on the image. What happens is your detector is like this, and then it has a border around it. And usually most detectors have a non-X-rayable border. And then this is your lung. If you've missed some of your lungs, what's going to happen is it's going to get confused because it's expecting the lungs to be centered properly, because our detector has been programmed to look for lungs like this with a nice white border on either side. If you produce an image that isn't in the center of your detector, you often get this confusing image where the detector produces this blackish border on the outside and you lose the peripheries. Just be mindful that your X-ray detector is designed to work from the center outwards. So always put your anatomy in the center of your detector. And I don't know why I included the hand, but let's just quickly talk about it. This is a overexposed hand X-ray, because you're losing the definition of your soft tissue margins here. It should be a lot more clean and crisp. Overall, the soft tissue and the bones look quite flat, quite gray. So the MAS was too high, and because it's quite gray, the KV was too high. Whenever you give me a statement on density and contrast, you would say something like, in terms of density, the image is overexposed because I cannot make out the soft tissue outlines very well, because the MAS was probably too high. I always expect students to be able to give me 3 points for any of their density or contrast statements. You must be able to tell me what is wrong with your image. Overexposed, high contrast, low contrast, adequate contrast. What structure on your image tells you this, and what factor is predominantly the cause? Again, because X-rays is a multifactorial image, we try to separate them into 2 things. By far and large, what I've mentioned, MAS, density, contrast, KVP, is true. But sometimes there is a bit of overlap, which we need to account for, but you shouldn't have a problem with that. All right. Are there any questions? My goodness, I have talked for nearly 3 hours. Any questions? Now is the time.